ते बनवून भात बारीक टाकून आता जेवायला बस तिखट पोळ्या पण ठेवल्या होत्या फ्रीज मध्ये. वेळ काय काढली काय म्हटलं वेळ काढली नाही झोपली जेवढू नाही तशी
Hello, good afternoon. Am I audible? Good to go? Okay. So, good afternoon, and I'm Dr. Nandini, the Senior Consultant and Head of Department of Anesthesiology at SRCC Children's Hospital, Management Narayan. And on behalf of my entire department, I welcome you all to today's masterclass, the theme being pediatric anesthesia. So I'm privileged to present today a glimpse of what we do together as a department, as a team, a snapshot of what I may say as of the work that we do, and also a span of what our responsibilities are, what our capabilities are, and all the departments we cater to. So before we begin, a little bit about the introduction to our department. We are 7 full-time consultants in our department, and we provide end-to-end services from the OT to all the peripheral areas as well. And this is something which you will see during the course of our masterclass as to what all areas we cater to and what we are sort of capable of. So we also conduct fellowship courses. We also have the DNB course in pediatric anesthesia with us. So essentially, these are all specialty pediatric anesthesia courses, and our students come to us post their MD or DNB for 1 year or 2 years, as the case may be, to train in specialty care. We have with us 7 of us. 3 of us are specialized pediatric cardiac anesthetists. Dr. Vaibhav Dhabe is a senior consultant in pediatric anesthesia. Dr. Lopa is a senior consultant in pediatric cardiac anesthesia, and Dr. Naveed is a consultant in pediatric anesthesia. And then on the general anesthesia side, there is Dr. Harick Shah. He's a DM in pediatric anesthesia. Dr. Priyanka Muneshwar is a fellow in pediatric anesthesia. She's completed a fellowship in pediatric anesthesia. Vedika has completed a fellowship in pediatric anesthesia. And I used to be in KM Hospital earlier, where we get course in pediatric anesthesia as also the fellowship in pediatric anesthesia. So essentially, in a nutshell, we are all specialists when it comes to catering for children. Okay. A bit about our patient profile. We manage sedation and anesthesia, and our patients range from newborns who may be extremely premature and until 18 years of age. And then also in some cases, we also deal with children who are older and who may have been, treating with us. Many of them are children and cognitively challenged as well. And our cases range from simple dental anesthesia, plastic, general pediatric surgery, complex patients including cardiac, oncology, transplants. We get a fair amount of referrals from across others and some overseas patients as well. And some cases are extremely difficult and challenging. They may be syndromic. They have been children who have not been able to be anesthetized elsewhere for want of safety, be it difficult airway, difficult venous access. So during the course of this masterclass, you will hear from my team, and all of us will be happy to take any questions regarding treatment and the management of our cases. So we will begin with our first talk. This is going to be delivered by Dr. Harick Shah. He is a consultant anesthetist with us and a DM in pediatric anesthesia. And he will be talking on the history of pediatric anesthesia and taking you a bit through where we were and where we have reached now. So over to you, Dr. Harick.
Good afternoon again. And what the results for
Oh,
this
7 वाजता नाही फक्त.
masterclass. So my topic is the development of anesthesiology, essentially the history.
ते तर पिंजरा पाडून ठेवला पण आला नाही म्हणजे ते खराब तर नाही झालं हो पण तो पोळी खाऊन जातो
नाही पोळी नाही खाल्ली.
नाही इथे खाऊन केला होता तो
So medicine we often is measured by the life we save. The history of anesthesia is measured by the
शेंगदाणे झाले काढून भेटून जाते
So before 1846, surgery was associated with terror, agony, high mortality. Speed was survival. Surgeons were judged by how fast they could amputate. And methods of restraint included strong assistant, leather straps, and pain relief would include alcohol, opium, hypnosis. So the term bite the bullet, literally, it was a literal practice of biting on a leather wood or to cope with the pain. So this date, October 16, 1846, we celebrate it as the World Anesthesia Day. It was the first public demonstration of ether anesthesia, and a lot of us consider this day as the single most important day in the history of surgery. And the surgeon famously quoted this saying that, "Gentlemen, this is no humbug," and patient could actually undergo surgery without much problem. Then after ether, we expanded into chloroform and nitrous oxide. So chloroform was introduced by James Young Simpson in 1847. It had faster induction, but it was often cardiotoxic. Then John Snow actually used it on Queen Victoria for painless labor, and we got the royalty approved of it. Then came in nitrous oxide or laughing gas, was first used by Horace Wells in 1844 for tooth extraction, demonstrating pain relief. But he faced initial skepticism after a failed public demonstration, but now it is stable and is still used today for dental extractions. So coming to why kids were different. So they have physiological differences in the sense of higher metabolic rate, smaller FRC, pronounced vagal responses. Then there are anatomical challenges like large tongue, anterior larynx, narrow cricoid ring. And so the whole narrowing of the airway where this Porcel's law is applicable is when there is slight edema to the airway, the diameter decreases by fourth power, and it can cause a lot of airway resistance. So so a lot of us, actually all the doctors also thought that infant pain is a myth. Pre-1980s, all the doctors believed so that neonate could not feel pain due to incomplete myelination of the nervous system. And consequences were the surgeries were performed on infants using only muscle relaxants and minimal to no anesthesia. So in late 1980 was a turning point where a research paper by Anand et al. Proved that neonates mount severe stress response to surgery, leading to higher mortality if unanesthetized. Then early pediatric techniques. So the early pediatric techniques included your open drop ether, where a gauze placed over a wire mask and ether was dropped slowly, literally called rag and bottle. It was a crude administration performed by a junior house staff or nurses. Challenges included hypothermia, hypoxia, and rebreathing under the drapes. Dr. Charles Robson is often considered the first pediatric specialist. In 1920s, he was at the Sick Children's Hospital in Toronto. Dr. Robson was first to devote his practice entirely to children. He perfected the use of specialized masks, established that pediatric anesthesia required specialized training and not just small little techniques. He described a trick to get his young patients to cooperate during induction. He would ask them to blow through the mask, and this we still use it. Next came Dr. Philip Ayer from England. So the problem was the existing adult valve and circle systems had too much resistance for babies' weak respiratory muscles. The solution was a simple T-piece tube open to air with no valves. Mechanism was fresh gas flow flushes out the CO2 during respiratory pause. Next was Dr. Jackson Rees and his patented Liverpool technique, where neuromuscular blockade and controlled hyperventilation were used during surgery, and nitrous oxide and low concentration of ether or other inhalation agents provided amnesia and further anesthesia. So Dr. Jackson Rees circuit is the one which we call as JR circuit, and which is still used currently in modern anesthesia practice. Then nurse Betty Lang was a nursing pioneer. She was a chief nurse anesthetist at Boston Children's Hospital from 1936 to 69. She developed cyclopropane technique for infants. She also helped develop pediatric size masks and equipment. And she also trained a lot of residents and fellows in pediatric anesthesiology. Next, coming to pharmacology. So from ether used in 1840s to what we use today is called sevoflurane. So ether and cyclopropane, they were difficult for kids due to smell and flammability. Then came in halothane in 1950s, which was the gold standard for decades. It had a sweet smell which allowed mass conduction. A risk was halothane hepatitis and bradycardia. Sevoflurane, which came in the 1990s, is the current king in inhalational agents. It is non-pungent, rapid onset and rapid offset, and it's standard for pediatric mass conduction today. Then there was airway management evolution. So rarely before 1940s, intubation was done. It was the first formulas for pediatric sizing were developed by Dr. Cole in 1957. PVC tubes came in by 1960s. So Deming in US and Dr. Jackson Rees in UK successfully pioneered routine intubation in their practices. Then Dr. Archie Brain in 1980s revolutionized airway management by production of laryngeal mask airway. Currently, we use all sorts of tubes and LMAs with different generations. And initially we used to think of putting only uncuffed tubes in pediatrics. Now we have smaller size cuff tubes and micro cuff tubes, which are excellent and a current gold standard in pediatric intubations. In coming to regional anesthesia, so Dr. August Bayer in 1898 was the first to include children for his spinal anesthesia trials, and he proved that neuraxial techniques were not exclusive to adults. Then, as and when the spinal anesthesia became more and more popular, there were development of spinal needles. The green needle in 1923 and Whitaker in 1951. Then Procaine was the first employed Novocaine, which was the initial drug which was used for spinal anesthesia by surgeon Heinrich Braun. Next came glucose addition, which we call as hyperbaric bupivacaine, and with that we could modulate the level of anesthesia. And combination of adrenaline was found to increase the efficacy of these agents. So slow and steady, these agents and these techniques and equipment was developed. Continuing with regional anesthesia, caudal block is the most common pediatric regional block performed. It was described independently by Fernand and Sicard as a key step in epidural technique. And in 1933, Meredith Campbell applied caudal anesthesia to pediatric urology, making its first use in children. And then the technique evolved from landmark era for decades, and we still use landmark technique very commonly to continuous caudal catheters and use of ultrasound for detection of caudal space. Then coming to the ultrasound revolution, introduction of high resolution ultrasound in the 2000s allowed anesthetists to visualize nerves and needle placement in real time, significantly reducing the complications like intravascular injections. So these three separate. So this is a brachial plexus block, which is a subclavian artery, the first rib, and this is the needle direction. You can see how close we are to the rib and the pleura. So with the use of ultrasound, we are avoiding all these complications which can happen while giving the block. And this is the caudal block, where you can see the needle puncturing the sacrocoaxial ligament. And this is a lumbar plexus block, which is considered a deep block. And with the use of ultrasound, you can easily give the block. Next is monitoring. So pre-1980s, monitoring was a finger on the pulse, listening to precordial stethoscope and color of the skin. Then pulse oximetry came in the 1980s. It is the single greatest advance in safety. It detects desaturation before the cyanosis appears. Then came in capnography, which confirms tube placement and ventilation adequacy. All of this impacted in decreasing the mortality, which dropped from 1 in 10,000 to 1 in less than 2 lakhs. Next came in the workstation. This was a simple ether inhaler. And over the years, we've progressed from all these to the current anesthesia workstation, which looks very complex and complicated with all the monitorings and agents and everything. So to conclude, anesthesia has transformed surgery from a desperate race against time into a meticulous life-saving art form. It has moved from brute force of chloroform ether to a balanced anesthesia of hypnosis, analgesia, and muscle relaxation. Advances in monitoring have reduced anesthesia-related mortality. The future is moving beyond sleep towards neuroprotection, AI-assisted dosing, and personalized genomic anesthesia. Thank you.
Thank you, Dr. Harick, for taking us through that walk through history. And next, I call upon Dr. Priyanka Muneshwar. She's consultant anesthetist with us, and she will take you through pediatric anesthesia. So when it comes to pediatric anesthesia, there is always a lot of apprehension. The family feels a lot of fear whether to undergo the procedure. And when we talk about anesthesia, there is a lot more confusion. So it is said that in pediatric anesthesia, you just don't treat the child, you treat the whole family. So how do we manage these little children? How do we manage and talk to the parents? How do we actually administer anesthesia? To hear about this, I called Dr. Priyanka to elucidate about pediatric anesthesia.
Good afternoon, everyone. I'm Dr. Priyanka, a consultant anesthesiologist at SRCC Children's Hospital. I have been handed over the task of speaking about pediatric anesthesia and give you a glimpse at a day in a life of pediatric anesthesiologist. So, pediatric anesthesia for us has proven to be a roller coaster ride. At one point, you are providing anesthesia to an 800-gram neonate, and the next moment, you are assigned to an 80 kg orthopedic patient. So, what sets this specialty apart from other arms of anesthesia is a unique and ever changing physiology in the range of patients. So, these factors include airway. The airway in pediatric patient is anatomically and physiologically different as that from the adults. The oxygen consumption is more as compared to the adults, whereas the physiological reserve is limited. These patients are just developing their temperature regulation system, and the neonates and infants are at a higher risk of hypothermia. We need to be cautious about the doses and dilutions while administering the medications to these patients. And pediatric equipments come in varying sizes, and it is imperative to choose the appropriate sizes for optimal functioning. Unfamiliar environment and the disease process itself gives rise to anxiety in patients as well as the parents. Top it up with communication barrier in smaller children, and it becomes a perfect cocktail for environment with heightened emotions. So we'll see these factors individually. Airway differences include narrow nostrils, larger tongue, loose teeth, compressible floor of mouth, horseshoe-shaped epiglottis, and placement of larynx higher than the adults. So for troubleshooting, we have to give proper positioning to the patient. We might have to use oropharyngeal airways, nasopharyngeal airways. We need to use the appropriate sizing of airway devices, be it the endotracheal tubes or the LMAs. Long circuits lead to increase in work of breathing. These things necessitate the proper airway assessment, which itself becomes difficult in smaller children because they are not able to obey your commands. Another aspect is that this set of patients desaturate faster than the adults because of the following reasons. The fuel problem being the consumption in children is almost 6 to 8 ml per kg per minute, as opposed to adults where it is only 3 ml per kg per minute. The tank problem, that is, they have smaller reserves, smaller FRCs, and the pump problem where they have the higher cardiac outputs. Psychological and parental concerns are there. Along with tackling the clinical part, we also need to address the psychological aspect of anesthesia, wherein they have wherein we encounter high parental anxiety. The child also gets anxious, mirroring their parents. So we need to ensure that both the patient and the parents and the guardians have a smoother perioperative experience during the anesthesia, and it includes counseling and using child-friendly strategies. So one of the most frequently asked questions for us is anesthesia safe for the neurodevelopment of the child. So what we usually say is, this is our patent answer, where we say that while preclinical data raises flags, recent high quality human trials such as the gas study, the panda mass study, it suggests that single brief anesthetic exposure in infants are generally safe for development. However, prolonged or repeated exposures warrant caution, and it is best managed by pediatric specialist anesthesiologists. So, coming to the safety in pediatric anesthesia today, it has been evolved, and it has been made possible because of advanced monitoring, standardized protocols like the PEDI registry, which tackles the problem of difficult intubation. We have pediatric advanced life support protocols. In addition to that, our hospital is JCI and NABH accredited, which ultimately results in higher safety profile in our hospital. Pediatric specific equipments are recently tailored more considering in mind the special needs of pediatric patients. And all across India now we are seeing that there are pediatric anesthesia courses, be it fellowships, the DM courses or the FNB courses. Coming to the preoperative assessment, we must make sure that we are knowing the child beforehand and formulate the plan accordingly. So in this pre-op assessment, we identify high-risk children early, optimize comorbidities before surgeries, set realistic expectations with parents. We order routine pre-op investigations according to what case the child is posted for. We assess the need of post-op either ICU or high dependency unit admission in case we need observation or need advanced care. And this is the time where we try to develop a rapport with the child and at the same time counsel the parents and resolve their queries. Coming to the red flags in pre-op assessment, any child having recent history of URTI or having active URTI, we have to pay more attention. We have to make sure that the disease process is not ongoing. We have to make sure that the infection is not so severe that it will lead to PRAs in children, that is the respiratory adverse events during the course of anesthesia. So there are some factors that we look at. We look at the WBC counts. If required, we look at the chest X-ray. We look at if the child is having fever or not, and accordingly we either we tailor our anesthesia according to the severity, or we uh, optimize the child. Patients with asthma or reactive airway disease need to be optimized. They um, uh, need to continue their nebulizations. We have to make sure that the disease is in control. Other red flags include congenital heart diseases, history of prematurity, previous anesthetic complications, or any allergies or any syndromic association. Preoperative assessment is also the time when we counsel the patients regarding the kneel by mouth status. We don't want our children to be fasting more than what is required, because it makes them more irritable, makes dehydration, makes them dehydrated, and it might also lead to uh, difficult IV access, or hemodynamics might be compromised because over NBM status. So for our infant, smaller child, less than 1 year, we have the guidelines which says the solids are recommended for before 6 years of the procedure, before 6 hours of providing anesthesia, formula feed for 4 hours, breast milk for 3 hours, or water and appy, which is a clear liquid, for 1 hour. For our patients more than 1 year, the NPO guidelines are simpler solids for 6 years and water or appy for 1 hour. Coming to how we tackle anxiety in children, why we need to tackle this problem, because several studies have reported that almost 50 to 80% of children experience pre-op anxiety, which is quite high, which leads to increased post-op pain scores, behavioral effects like enuresis, nightmares, separation anxiety, PTSD. They might have emergence, delirium, might have to undergo prolonged PACU stays, high opioid consumptions because of the increased post-op pain. They might develop abnormal sleep patterns or long-term psychological effects like PTSD, which might lead to avoidance of further medical treatments. Coming to what measures we take to elevate this anxiety. So this is one of the thing that we do. This is a fun and informative booklet devised by Dr. Nandini, Dr. Bela, and Dr. Sachi, who is a psychologist. We take through the children who can understand, who can read, through the procedure, and we elevate their anxiety, we prepare them, and we tell them what is being done and why it is necessary. So this has helped us a lot, minimizing our pre-medications, minimizing the anxiety. If these distraction techniques or these measures are not working, then we need to assess the need of pre-medication. So what we do is we explain mass induction to the child, develop rapport. If all these things fail, so we might have to pre-medicate the child. That means we usually give some oral medication or nasal medication to make the child calm, and then we take the child inside OR, giving them anesthesia gas and putting them to sleep. Other option is putting an IV beforehand with aids of equipments like Buzzy Emla cream, which facilitates a smoother IV insertion, and we are good to go. Distraction technique like taking them in the car or playing with them and showing them screens, because most of the patients, children nowadays are hooked to their screens. They have usually their favorite videos, their favorite cartoons, favorite reels, and you give them a screen and they just won't even look at their parents, and they're happy to come with you inside. Other thing is like keep playing with them, talking to them, making sure that they are not fearful, making sure that you are not going to poke needles to them. So these methods usually help us a lot. This video shows us how we are inducing a child with the help of her favorite toy. So this doll is her favorite toy, and we are explaining her, we are showing it on the doll that we are putting the pulse socks, and then she is allowing the pulse socks on her hand. Then we are showing that how we are putting the mask on the doll, and then she is readily allowing the mask. So this is once the mask is accepted and the anesthesia gas goes in, we get a win. Coming to next video, this is where this video shows the importance of choices that we give to the patient. If we give them a choice, do you want an IV or do you want a face mask? They then don't lose that sense of control. They feel that okay, they are in control, and then they feel that it is their choice and it is them that they are doing this, and they are okay to go ahead with the mask induction. Like we can see in this video, the child is very much accepting the mask. He doesn't want us to hold the mask. He's like, I will only hold the mask, and it was a smoother induction. Coming to the OT preparedness, usually before taking the child in, we make sure that we have all the plethora of our airway devices and adjuncts, and that our medications are labeled and prepared according to the doses of the child. This is the modern high-end anesthesia machine comprising of the multipara monitor, the ventilator, and the anesthesia gases. Coming to intraoperative anesthesia management, after securing IV and airway, we maintain the anesthesia either with intravenous agents or the anesthesia gases. We make sure that the hemodynamics are maintained within the normal limits, and We do this standard monitoring, fluid management, and pain management. For some cases, we might have to use invasive monitoring like invasive blood pressure monitoring, cardiac output monitoring, according to the nature of the case. And for some cases, we might also have to use bispectral index monitoring, mostly in the neuromonitoring cases. All these monitoring parameters will be explained to you in detail in the subsequent talks. So, one of the most important aspect of pediatric anesthesia is good pain management. So, at our hospital, we use the multimodal analgesia approach, in which we use our central neuraxial blocks or regional nerve blocks, facial plane blocks, and IV medications for the pain management. So this picture that we can see is the most commonly performed block, that is the caudal block, which takes care of pain. This is a video where we can see that we are giving a facial plane block using the USG machine. This is a brachial plexus nerve block, where we can see that the brachial plexus is beautifully seen in this video, which is being blocked with the use of USG. So USG has evolved the practice of pediatric anesthesia very much by leaps and bounds. Now we use USG, whether be it regional blocks, vascular access, focus, for example, echo, your transesophageal echocardiography, gastric focus, or lung ultrasounds. As well as we are also nowadays employing USG for airway assessment. Here we can see the picture on your left is where we are employing USG as well as the nerve stimulator for giving an advanced block, that is lumbar plexus block. So this dual technique enhances the safety. By USG we identify the landmark, and PNS helps us to identify the nerve components, as well as to make sure that we are not directly injuring the nerve components. The video over here is showing how we are using ultrasonography for our vascular access. Particularly here we can see that the radial artery is being cannulated with the use of USG. It is recommended that we use USG because it increases your first pass access. Coming to the 10 M's of pediatric anesthesia quality checklist, throughout the conduct of anesthesia, we have to make sure that if we are following this checklist, that there should be no fear, there should be normovolemia, normotension, the heart rate, the hemodynamics should be normal, the oxygen content should be normal, CO2, there should be normocapnia, normonatremia, normoglycemia, normothermia, and there should be no post-op discomfort. One of the most important thing of pediatric anesthesia is its holistic approach. So not only pre-op or intra-op, we have to make sure that post-op also the child is very much comfortable and safe as well. So not all children are suitable for daycare surgery. Some of them might require high dependency unit or PICU backup, maybe for observation, maybe for post-op ventilation, maybe for pain management, and appropriate patient selection usually improves outcomes. Holistic approach, we identify the high risk patients, and anesthesia, as we'll see throughout the subsequent talks, it is a collaborative effort. The pediatricians, the surgeons have a huge role to play, where they help us know our patients better, they help us optimize our patients better, and we need their support throughout the conduct of anesthesia. So to summarize, children are physiologically and psychologically unique. Pre-operative optimization is very important, at it reduces the risk. Early communication improves safety and satisfaction of both the patient and the parents. A special and specific skill set is definitely required for dealing with this set of patients, and team sport is always an important aspect. Thank you.
Thank you, Priyanka, for walking us through pediatric anesthesia and what makes pediatric anesthesia so different from general anesthesia or anesthesia for adults. And to those of us, of you all who are tuning in, do send your patients to us. We are all specialists here, and if you have a child who needs anesthesia or sedation, I think SRCC is the place to go. So from pediatric anesthesia to the next topic, and I'm going to talk about fetal interventions. So about 3 years ago, we started obstetric anesthesia with the intention of caring for fetuses or newborns who have congenital birth defects. So we actually started fetal interventions first and then realized that if the mothers deliver here, it's actually better for the newborns. So since the last 3 years, we have done a small share of fetal interventions. In the next segment in this small session, I'm going to walk you through what we have done, our experience, as well as what does it mean to care for the unborn child, and how we go about it. So what has happened over years is that advances in prenatal or antenatal testing for the fetus has enabled us to pick up these fetal anomalies in utero. And timely treatment, we know that can actually reduce morbidity and fetal mortality. So with this goal in view, we have started, we are able to administer anesthesia to the fetus and improve their well-being. So what are the indications for fetal surgery? There are some malformations in the baby, in the unborn child, which would impede organ development irreversibly. But if corrected in time, it can allow normal development. And that is where the focus of fetal surgery is. The focus has actually shifted from mere survival of the fetus to a reduction in morbidity. And that is the key to fetal intervention. Now, there are some prerequisites before the team embarks on such a important or such a challenging journey. One is a careful risk-benefit analysis. Because what happens when families come to us, when families come to the surgeons for fetal interventions, because they know now that the unborn child has got a birth defect, the mother is going to, willing to go to any extent to undergo the intervention. So it's important to counsel the family, counsel the parents as to what is the risk benefit, because we are caring for two patients, the mother as well as the unborn child. And it is important that the family understands what is going to be the extent of the benefit when we are dealing with a fetal intervention. So it is a multidisciplinary, team-based approach, and it's very, very important to have an ethics oversight as well to see how much we can make things easier by tackling this problem in the womb rather than wait for the child to be born. So it needs, of course, centers with expertise, people with experience, appropriate infrastructure and facilities in a center such as ours before we can undertake such a mammoth task. So when it comes to fetal interventions, key focus areas are: one, for us, it's important that we maintain the uteroplacental circulation. We must understand here that the placenta is the key, which is providing oxygen and other vital nutrients to the patient. So it's important that at all times during the intervention that the uteroplacental circulation is maintained. The other thing is to achieve uterine relaxation, because when instruments are being put into the uterus, the natural tendency for the uterus is to contract. And this is one of the jobs for the anesthesiologist, for the obstetrician, to ensure that the uterus is relaxed so that the surgeon can perform the procedure. Optimizing surgical conditions so that the procedure can be done safely, monitoring fetal hemodynamics. So whenever there is a threat to the placental circulation, when there is the fetus can go into bradycardia, and that is something which we must monitor and prevent and treat so that the fetus continues viability. And of course, overall, ensuring maternal and fetal safety is the prime goal for the entire team. So broadly, we can classify fetal interventions into three types. One is a minimally invasive interventions, which are essentially what we call keyhole surgeries. The second is the open mid-gestational fetal surgeries, which essentially involves a hysterotomy and then performing the surgery. And the third kind of intervention is what we call the exit procedures. These are usually done near term. That means it's a ex utero intrapartum treatment, and I'll come detail it in the subsequent slides. So coming to the first set, which is the minimally invasive interventions, these are usually done in the first trimester or the mid-trimester, and these can be either needle-based techniques or fetoscopic interventions, as the name suggests. These are minimally invasive. So it's actually least risk to the mother and the fetus, and least risk of complications such as premature rupture of membranes, premature labor, bleeding, etc. So what are these procedures? These can be simple procedures like percutaneous umbilical blood sampling or radiofrequency ablation for selective fetal reduction. Suppose there is one viable twin and the other twin is not viable, or one twin growing at the expense of the other, you might need to sacrifice one twin. That's what we mean by radiofrequency ablation for selective fetal reduction. Sometimes there are multiple pregnancies, gestations which are not compatible with life, and then we need to do a selective reduction. Balloon valvuloplasty for aortic stenosis, or a shunt placement, say, for a bladder outlet obstruction. These can also be done through a scope, the fetoscope with ultrasound guidance. The commonest procedures done, including what is done at our center, was a laser photocoagulation for twin-to-twin transfusion syndrome. And I'll show you the subsequent slides for that. It could be a tracheal occlusion for a congenital diaphragmatic hernia, amniotic band release, ablation of posterior urethral valves, which can ultimately, if not treated, could lead to renal failure, or shunts like a vesicoamniotic or a peritoneoamniotic shunts. These are usually performed under local anesthesia and sedation because these are minimally invasive, so there is not much pain involved for the mother. So we try to avoid general anesthesia, and we give minimal sedation that also if required, and mostly this can be done under local anesthesia so that there is not much medication administered to the mother in the first trimester. So this is a video which is showing a twin-to-twin transfusion syndrome. Now what happens in a twin-to-twin transfusion is that, sorry. Yeah. So what happens in a twin-to-twin transfusion syndrome is that in a monochorionic pregnancy, what happens is very often there are abnormal connections in the placenta through between the two twins. So there is one twin which is growing at the expense of the other. So the twin which is the blood is being shunted through these abnormal connections to the other twin. So one twin becomes oligo, is not getting much blood flow, and there will be oligohydramnios. There will be subsequent fetal demise if you don't do anything. On the other hand, the twin which is growing also can develop cardiac failure because of over transfusion. So what is done in this situation is that you can go in early in the first trimester, and using a laser, we can actually burn these abnormal connections so that the balance is restored, and both twins can then hope to thrive until term. So this is essentially what is done. This is the laser photocoagulation for the twin-to-twin transfusion syndrome. So this is a pictorial representation as the same, and you can here see that there is a donor twin, which is basically shrinking, or the blood is being channeled into the other twin, which is the recipient twin, and if not sort of intervention is not done in time, that both the twins are not going to survive. So in the first trimester, typically what is done is using a fetoscope through the maternal abdominal wall, through the uterus. These connections have been previously mapped, and then they are selectively ablated. And during the procedure also, we do it under ultrasound guidance. So this is something which is one of the commonest procedures which is done with the good evidence for benefit for the fetus and with very low risk to the mother. And we have done about 4 procedures here at SRCC. This is our video where the actual video of the noise. So you can actually see that the laser is being used. It is being guided through a fetoscope, and the other connections are being photocoagulated. The next procedure, which is done which can be done through a fetoscope, is for a condition which is known as congenital diaphragmatic hernia. Now, here what happens is the fetus, here the diaphragm is deficient, and that leads to a herniation of the abdominal organs into the fetal thorax. So what happens is there is pulmonary hypoplasia, and that lung on that side cannot grow because the herniated abdominal contents are pushing the lung, the fetal lung. So pulmonary hypoplasia develops in the fetus, and in fact, the mediastinal shift can also cause pulmonary hypoplasia on the other side. So all in all, if not corrected, you might say that you can deliver the newborn and then correct the congenital diaphragmatic hernia, but sometimes the pulmonary hypoplasia is so severe that the fetus cannot, the newborn cannot survive because of the severe pulmonary hypoplasia. So in case we have antenatally detected it, and there are measurements which can be done in utero using fetal MRI, fetal ultrasound, and we know that the pulmonary hypoplasia is going to be very severe, there can be a procedure which is done in the first trimester or early second trimester. It is called a feto procedure, which is essentially a fetal endotracheal occlusion. So what is done is through via a fetoscope, you pass in a catheter with a balloon into the fetal trachea. And essentially what you're doing is you're inflating the balloon inside the trachea of the fetus and plugging the lung. And it is believed, and there is evidence to show that by plugging the lung, normally the fetus will produce lung fluid, which is secreted out into the amniotic fluid. Here by plugging the lung, what we are doing is we are preventing the egress of the fetal fluid, and that is believed to cause expansion of the fetal alveoli and increase the lung growth. So this is supposed to decrease the pulmonary hypoplasia. So by doing this feto procedure in the first or the second trimester, what we are doing is we are allowing the fetal lung to grow. And then at the end of the gestation near term, there is another procedure where we can deliver the fetus, and we can do an exit procedure where we remove the balloon, or we can do a procedure such as near term where again through a fetoscope we can puncture that balloon and allow the baby to be delivered and then breathe normally. So this is a feto procedure which is done fetoscopically through minimal access procedure. This is another procedure which is done for via a fetoscope for meningomyelocele. So meningomyelocele, is a defect in the spinal cord where the contents can protrude out. And here again, there is evidence to show, there is in fact very strong evidence to show that if this is corrected in utero, it can actually prevent the onset of hydrocephalus and reduce the incidence of, motor disabilities later on. So because meningomyelocele nowadays are being corrected, till now are being corrected after the baby is born. So it is connected after delivery as early as possible. But if it can be done through a fetoscope in utero, there is evidence to show that there is better benefit. Coming to the second segment, we finished the fetoscopic interventions which are done in the first trimester. We can also, the second segment is the open mid-gestational fetal surgeries. So as it suggests, this is done via a laparotomy. So there is the mother is usually, it can be done either under spinal or even general anesthesia. And here the uterus is opened, and then the open repair of defects such as meningomyelocele or sometimes a large fetal lung mass, debulking of a very large sacrococcygeal teratoma can be done, or even a vesicostomy for a bladder outlet obstruction. So these are inherently open surgeries, which means there is an increased risk for bleeding, for fetal compromise, for premature rupture of membranes, and these mothers are going to definitely need a cesarean section if the delivery continues to turn. So essentially risky procedures are not often done because the risk sometimes overweighs the benefit. So this is a picture showing the open hysterotomy. This is a hysterotomy, and you can see that the meningomyelocele has been sutured here. It's a primary closure, and the second diagram, it is a patch which has been put over a very large meningomyelocele. So here then this is done as we discussed in the mid gestation. So then the hysterotomy will be closed the pregnancy will be continued till term, and the mother then will be delivered as near term as possible. Also, a hybrid approach has been described where the uterus can be delivered outside, and then instead of doing a hysterotomy, you can pass a laparoscope or a hysteroscope through that, and then so you kind of achieve the best of both worlds. So it's a hybrid approach which has also been described for a MMC or meningomyelocele repair. The last segment is the exit procedure, which is essentially an ex utero intrapartum treatment. By this we mean that it is performed close to term gestation on placental bypass. So here what is done is there are certain conditions where the newborn, if delivered, cannot breathe on its own or will not be able to manage the airway on his own. So for example, if there is a large neck mass or there is severe micrognathia, then this newborn, if you allow a normal delivery and you expect that the baby will breathe on its own and maintain oxygenation, that's not going to happen. So here what is done is while the baby is still connected to the placenta, we will be performing a procedure to maintain oxygenation. That could be a tracheostomy, that could be endotracheal intubation, and then the umbilical cord will be cut. So it could be commonly done for airway malformations or resection of a large intrathoracic mass. Sometimes in severe cardiac conditions, for example, severely hypoplastic LV, what can be done is the ECMO cannulation can be done when the placenta is still attached, when the baby is still attached to the placenta. Also, these congenital diaphragmatic hernia for fetuses, if the trachea has been plugged using the fetal procedure, then what we will do is we will deliver the fetus, and while the umbilical cord is still attached to the placenta, the unplugging of the tracheal balloon will be done, and then the umbilical cord will be cut. So usually these procedures are performed under general anesthesia, and these are the indications for the exit procedure. So it could be exit to airway, which means a very large airway malformations, could be a cervical teratoma, could be lymphatic malformations, could be an intrinsic obstruction like what is known as a chaos syndrome, that is a congenital high airway obstruction syndrome, could be laryngeal atresia, where you would do a tracheostomy and then cut the umbilical cord. Could be exit to resection of intrathoracic masses. It could be exit to ECMO in severe cardiopulmonary compromise, or exit to separation in case of conjoined twins. So this is a picture showing how the fetal MRI has already detected a very large airway malformation, which is not deemed fit that the patient would be able to, the newborn would be able to breathe. So here you can see that the tracheostomy has been done, and you can see how large this airway mass is. It would be impossible for the newborn to breathe and maintain oxygenation using the upper airway. So coming to anesthesia, the choice of technique really depends upon what is the planned surgical approach, what is the extent of fetal surgical stimulation, what is the maternal medical history, and also the patient and the surgeon's preference. So here it is important. Now here the anesthesiologist is taking care of two lives, both the mother and the baby, the newborn baby, or even the unborn baby for that matter. So here what happens is the mother is actually, we are doing all this for the fetal benefit, and the mother is actually, if I may say so, only a bystander. So it's important that the anesthesiologist really understands the maternal physiology and does everything in his or her capacity to take care of the mother, because there can be no risk to the mother allowed. So we all know that during pregnancy there is a whole lot of changes which are occurring in the maternal physiology, including an increase in the cardiac output, increase in the blood volume, the respiratory system. There is an increase in the oxygen consumption, a reduction in the FRC because of the growing the fetus. There is an increased risk of aspiration because of the change in the gastroesophageal angle. So also the airway undergoes changes. There is mucosal edema, increased vascularity. The tube sizes, the endotracheal tube size which the mother will take will be smaller. So it's important that an anesthesiologist who understands all this is kind of in charge of the mother and also the fetus. So paramount is ensuring maternal safety, which means that from the second trimester onwards, we are going to ensure left uterine displacement here, because the growing baby is pressing upon the IVC, the inferior vena cava, as also the aorta. So if the mother is allowed to lie supine, there could be hypotension. So simply to maintain the blood pressure, we must ensure that there is left uterine displacement. Also, there could be a need for invasive monitoring, which means invasive arterial access and the additional IV access for the mothers, more so for exit procedures, because these are extremely risky procedures. There could be torrential bleeding because the uterus is being relaxed so that the baby could be delivered and the procedure could be done, the placenta doesn't separate. And during this time, there could be ongoing bleeding, which could put the mother at risk. So it's important that we address that. So we need to give tocolytics to relax the uterus when the surgeon is working, and these can cause maternal hypotension. And also because tocolytics are given, this can actually lead to a bleeding risk later on, especially during exit procedures, because here the uterus is relaxed. And as you understand, at the end of the procedure, the uterus needs to contract. So during that time, we need to give the antidotes, if I may say so, to cause the uterine contraction. And if that is not done in time, the patient can really bleed severely. So this is something which we need to kind of pay a lot of attention to. Coming to the fetal physiology, now the fetus is extremely precarious. The cardiovascular system is still undergoing development. It's a parallel circuit with the blood volume is hardly 100 to 150 ml per kg. You can imagine the whole blood volume of the fetus is about, for a 1 kg or a 2 kg fetus, is just about 100 to 200 ml. So even a small amount of bleeding can put the fetus at risk. 50% of that blood volume is in the placenta. So you can imagine how much important that placenta is to provide oxygen and other vital nutrients to the baby. So if there is premature separation of the membranes, if there is reduced blood flow to the placenta, the fetus is going to not be viable. The cardiac output of the fetus is maintained by heart rate, and so bradycardia in the fetus. So if there is any stress to the fetus which can occur during a fetal intervention, be it hypoxia, hypothermia, or any noxious stimuli, which are common stressors, the fetus will respond with bradycardia, and anything less than 100 is something which needs to be treated very, very urgently. A $1 million question which everybody asks is, does the fetus really perceive pain? We know that the thalamocortical connections necessary for pain perception develop by about 23 weeks to 30 weeks. But noxious stimuli, which can occur during these fetal interventions, can elicit neuroendocrine and hemodynamic responses by as early as 18 weeks. So we need to address that as anesthetist. So increased catecholamines, cortisol, which can all occur because of the neuroendocrine stimulation, increases the placental vascular resistance, and this reduces the blood flow to the fetus. All this can cause uterine irritability and premature labor, which needs to be prevented. Procedures on non-innervated fetal tissues, for example, the placenta, where I showed about the twin-to-twin transfusion, or the umbilical vessels, they do not really need fetal analgesia. So the anesthetist who's managing these kind of cases needs to understand exactly what is the procedure. Do we need to give some anesthesia to the fetus or not? So the anesthesia considerations in a nutshell are maintaining adequate uteroplacental blood flow, and what can compromise this needs to be avoided. So any reduction in oxygen delivery to the uteroplacental circulation, any decrease in umbilical cord perfusion, any reduction in the delivery to the oxygen delivery to the fetal tissue should all be avoided. So this is a busy slide, but essentially we need to know that all the tocolytic agents which we give to relax the uterus all can have maternal side effects like maternal hypotension, platelet dysfunction, muscle weakness, tachycardia, arrhythmias, and this is something which we need to be very vigilant about and prevent and treat it if the need arises. Again, uterotonics, which are given to contract the uterus following the exit procedures, can also cause side effects, and that also we need to know. Now, these are the obstetricians will know that these are the common agents which are given after a cesarean delivery, and this we need to give following the exit procedure and after the newborn is delivered. Now, fetal monitoring is also very important, and this here pre-procedure we will, of course, the fetus would have undergone extensive evaluation using ultrasound, a focused echo or MRI, and during the procedure also we will be monitoring using Doppler or echo in open procedures, and in exit procedures even a fetal pulse oximetry. Now about fetal anesthesia. Now, if the need demands, like there are specialized procedures which are done, either the exit procedures or the fetoscopic interventions. We need to give medication to the fetus. Now, this can be done either by giving the medication intravenously to the mother. The mother is under anesthesia. But here the transfer occurs through the placenta, and not all the medications will go through the placental barrier. So the mother might need higher medications, in larger doses, and this may not be probably the best approach in all cases. So preferably the medications are given directly to the fetus. This can be given intramuscularly through the uterine wall. So commonly used medications are again which need to be safe for the fetus. So opioids in higher doses. Rocuronium is a muscle relaxant. Especially it is needed if you're doing very specialized techniques. Like for example, if you need to put the tracheal balloon for a CDH, the fetus should not move. So in this case, the muscle relaxant will also be given, and atropine is also usually given to prevent fetal bradycardia. In addition, the anesthetist needs to be very vigilant to see if there is any fetal compromise, any hypotension or a cardiac issue. Then adrenaline is always kept loaded to be given if need be. So also normal saline if there is a hypovolemia. Again, on the right-hand side is the airway equipment. This is used for the exit procedure. So if we are delivering the fetus and we need to perform some procedures like say gain access to the airway, either the direct laryngoscope or the video laryngoscope, endotracheal tubes of all sizes, and if need be a rigid bronchoscope. So anything to get access to the airway, flexible bronchoscopy if need be, or a tracheostomy if a direct laryngoscopy or video laryngoscopy is not possible. Then we may need to go directly for a tracheostomy to gain access to the airway till the baby is still attached to the placenta. This is a pictorial diagram showing the exit procedure, and you can see it's a busy slide because you need a whole lot of people to care for the mother and the baby. So here you can see that we are in readiness, and this is something which if you were to do an exit procedure, the drills would have to be done beforehand. So as you can see, this is the mother. At the head end, you have the maternal anesthesiologist, the anesthesia assistant. You have a timekeeper, and this person's role is extremely important because the placenta is going to separate at some point of time. So we have to be very, very cognizant of time, and whatever we are doing to save the baby or the tracheostomy or the intubation has to be done in a very time-bound fashion. Then, of course, at the foot end, you have got the pediatric anesthesiologist, the pediatric surgeon ready to receive the baby, and you have the obstetrician who's ready to do the hysterotomy, deliver the fetus. So it's a whole lot of people. The neonatologist is here to take care of the baby, and of course you have the whole host of equipment which is ready to manage the exit procedure. So this is just a representation of how we would plan for an exit procedure. We haven't done one yet at SRCC, but anytime the need arises, we are in readiness. And if you have a patient who has a malformation, this is the place to refer to. And the entire team is geared to do a procedure of this magnitude. So how you would plan for a procedure? You have the patient who has an abnormality. So say maybe it's a neck mass, or maybe it's a tracheal anomaly. So the prenatal counseling would have to be done. We would plan for an exit procedure, and we would have our plans in place. For plan A, maybe we plan for a direct laryngoscopy or a video laryngoscopy. It fails. We move in a time-bound fashion to plan B, which could be rigid bronchoscopy or fiber optic intubation. Plan C would be tracheostomy, or plan D would be ECMO. So the thing is to have a plan in place, what to do when a plan A fails, move quickly to plan B, plan C, and plan D. So the essence of this is that you have to have a center and a team which can go through all this. I mean, from plain laryngoscopy to an ECMO quickly if need be. So this is a picture where we are showing that the baby has been half delivered out of the fetus, out of the womb, and the tracheostomy is being done while the baby is still connected to the placenta. This is another picture where an intubation has been done, and you can see that here the baby is half delivered out and in a time-bound fashion. Once you have got access to the airway, oxygenation can start, and then the umbilical cord can be cut. So we're talking about all this, but what is the evidence? Because when you're going into procedures which are risky, which are not without complications, we need to have solid evidence. So two very what can I say, robust trials are the twin-to-twin transfusion syndrome, where we know that the blood is shunted between these vascular anastomosis, and if it is not intervened in time, it's got a 80% mortality. So the big evidence is the Eurofetus trial, where we're talking about laser photocoagulation of the abnormal anastomosis, and that is proven to have improved perinatal survival and fewer short-term neurological abnormalities. The second big trial was the MOMS trial, which is the management of meningomyelocele study. And here, when it is repaired in utero, there is a reduced incidence of hydrocephalus, improved mental and motor development after prenatal surgery compared with the correction of after birth in patients assessed at 30 months. So this is robust evidence, and this is I mean, a huge impetus to intrauterine surgery. Now, the procedure is not without complications. So there are a host of complications which can occur, and this is where the counseling part comes in. So premature labor, preterm delivery, pulmonary edema because of the tocolytics, we gave postpartum hemorrhage, especially during exit procedures, and uterine scar dehiscence. So this is all about teamwork. This is, I mean, neonatologists, pediatric anesthetists, pediatric surgeons, intervention. This is Dr. Chandralula with us after our first intervention, which we did about 3 years ago. So all in all, a very niche procedure which needs a team, which needs a center which can manage the patient through the process and manage any complications if the need arises. Thank you for signing in. If you have any questions, you can put it in the chat box or ask in the end if need be. Yeah. So for our next talk, I call upon Dr. Vaibhav Dhabe. He's Senior Consultant, Pediatric-Cardiac Anesthesia, and he's going to talk about monitoring. So what happens is when the surgeon is doing his job, the anesthetist is at the head end, looking at every parameter of the child, right from the simple pulse oximetry to very advanced monitoring, which could be NIRS, and Dr. Vaibhav will run you through it. And essentially, every second, your patient is being cared for by the anesthesiologist at the head end. So to hear about simple to complex monitoring, I request Dr. Vaibhav.
Good afternoon, everyone. So my talk is on monitoring in pediatric anesthesia. So over the next 25 minutes to half an hour, I'll be talking on monitoring in pediatric anesthesia. I will try to give you overview about various in monitoring modalities, their importance, and some limitations. Basically, monitoring in during any anesthesia procedure forms the backbone of the anesthesia management. It helps you for the intervention, or also how your intervention is going on. You have to monitor the patient during the procedure. So patients will have physical signs, comorbidities, various types of procedure, how the surgical field is looking, what anesthesia drugs and techniques are used. Depending on that, patient will have their dynamic physiological changes, and accordingly we have to tailor an individual monitoring plan for each patient. So in this, during next half an hour, we'll go through the physical signs, pulse oximetry, ECG, capnography, capnometry, hemodynamic monitoring, depth of the anesthesia monitoring, neuromuscular monitoring, echocardiography, temperature, and some other monitors. So we'll start with some physical signs. When the patient comes in the OT, we have to see how the color, temperature, and dryness of the mucous membrane, like hydration and physiological status. Is they are sunken or swollen? Are there any signs of airway obstruction? Anterior front tunnel, whether it is bulged or sunken. Capillary filling time, as you can see in neonates, we can check on sternum. If it is more than 2, then it is delayed. Then peripheral pulses and urine volume and color, which will help you manage your anesthesia plan. So we will start with pulse oximetry, which is most common non-invasive monitor, which is used in most of the places, from wards to ICU to OT to ER. Corona has increased its spread widely. So it is a non-invasive monitor which provides beat-to-beat oxygen saturation of patient's hemoglobin. The arterial saturation is determined by using ratio of light absorption between the two wavelengths, 660 and 940 nanometers, which is oxy and deoxy hemoglobin. The reading between 80 to 100% correlates with in vitro results. So less than 70%, when it shows less than 70%, it poorly correlates with the oxygenation. The slides are finger, palms, toes, ears, and wrist. Soles are used in neonates for pulse oximetry. Measurements of preductal, which is in right hand, and postductal pulse oximetry or SpO2 facilitates diagnosis and reversal of shunt across VSD or ASDs. So what are the limitations? It cannot display hyperoxia. It overestimates saturation in polycythemia and underestimates in anemia. Hypovolemia, hypothermia leads to reduced perfusion, affecting the readings of SpO2. In neonates, burns, carbon monoxide poisoning, SpO2 is overestimated. Nail polish meconium in neonates interferes with the reading. Ambient light source, motion, and electrical artifacts also affect the reading and the accuracy. So accordingly, there are derived index. So yeah, as you can see here, this is the pulse plethysmography, and this is pulse oximetry. PI is pulsatility index, and this is pulse rate 91. Accordingly, from this pleth variability index is derived, which helps in determination of the volume during surgery, hypovolemia during surgery. Co-oximetry is the new modality which is derived advanced form of pulse oximeter, where there are 8 wavelengths, and it gives you methemoglobin and SP carboxyhemoglobin and HB and various other readings. These are various types of probes and various sites where you can monitor pulse oximetry. Next will be most commonly used in OT will be ECG. So this is how the normal electrocardiogram looks. There are 3 positive deflection P, R, and T, and 2 negative deflection Q and S. Depending on that, there are a PR interval, ST interval, and TP interval, and QT interval, and there are segments like PR segment and ST segments. Speed of ECG paper normally is 25 mm per second, where small box ranges for 0.04 seconds and the big box is 200 milliseconds. So these are the normal values which you should keep in mind. During evaluation of ST segment elevation, this reference is this PQ or a PQ isoelectric line which is used. So how the basic, one of the important use of ECG is rhythm interpretation. So when we look at any ECG, these 6 steps are to be followed: rate, regularity, P wave examination, PR interval, QRS width, and rhythm interpretation. So there are 2 methods by which you can calculate the rate. Large box method is 300 these big boxes which are seen in the ECG between two RR interval. So you divide 300 divided by this large box, you will get the heart rate, that is 74. Then small box method is 1500 divided by the small boxes which are 10 in two large boxes. So you divide 1500 divided by 20, it is 75. Second is regularity. Here you have to see assess the two RR waves and R2R interval, which has to be regular. If it is irregular, then the RR interval looks irregular. Do the then the that is ventricular rate, and then you have to assess for P wave irregularity also. Third step is P wave examination. P wave you have to identify, and it should be regular. It should have symmetrical shape and should all look alike. And there should be one P and one QRS complex for each ECG waveform. So abnormal P wave is not followed by QRS complex, or there are more P wave than QRS complex. Then PR interval also needs to be seen. Normal value is 0.12 to 2. PR interval is time taken from SA node to AV node, and abnormal when it is greater than 0.2 seconds. The PR interval is irregular. It may indicate some type of SA to AV conduction problem, possibly conduction block. Then QRS complex, it is measured from beginning of Q wave to the end of S wave. Normally it is not more than 0.12 seconds. The QRS complex have uniform throughout. All QRS complex are equal duration and width. RR interval between each complex has to be regular. So what are the abnormal findings? They might vary in shape, width, and direction. If it is more than 1.12 seconds, it is wide, and RR interval if between the QRS complex is regular, it is abnormal. Then ST segment represents the ventricular repolarization. It should be electrically neutral. T wave is upright whenever R wave is upright, and the T wave deflects downwards when the R wave is deflected downwards. If ST segment is more than 1 mm elevated or depressed, it is ST elevation. The T wave is in the opposite direction of R wave, that is also abnormal. So some rhythms we will see. So look at this rhythm, what you can see. The correct is, it is a normal sinus rhythm where the heart rate is around 60 to 100, and each P will be followed by a normal QRS complex. Second, can you identify this rhythm? So this is sinus bradycardia where heart rate is less than 60, P wave and QRS complex are normal, but rate of heart is low. So what is this? So this is atrial fibrillation where rhythm will be irregular and P waves are characteristically absent and replaced by fine chaotic waves. The ventricular rate is usually variable and may be slow, normal, or rapid. So patients with symptoms usually have rapid ventricular rate, and PR interval will be absent, and the QRS complex is normal or may be widened. So here you can see characteristic flutter waves. This is atrial flutter. It can be regular or irregular. For atrial flutter, atrial rate is extremely fast, around 250 to 350, and ventricular rate is typically slower than the atrial rate. So you can see the sawtooth flutter waves in the picture. What is this? This is usually what happens when we run. This is sinus tachycardia. The rhythm is regular, but heart rate is more than 100. And P waves will be normal and maybe a round or buried T wave if rate is very fast. What is this? This is a asystole. There is no discernible electrical activity on ECG monitor. The isoelectric line may have a light or intermittent deviation away from baseline. When asystole is present, there may be intermittent agonal rhythm, which will usually have a wide or bizarre form. So this is second degree heart block type 1. For second degree heart block type 1, you can see the PR interval gradually widens, and then there is drop in QRS complex. So P waves will be regular in this second degree type 1 heart block. This is SVT. supraventricular tachycardia, rhythm is regular, heart rate will be 150 to 250. P wave will be merged with T wave, and if measurable, PR interval will be normal. The QRS will also be normal. This is second degree type 2 heart block, where there is intermittent drop in QRS complex. P wave usually look normal, and there will be more P waves than QRS complexes. This is ventricular fibrillation. For ventricular fibrillation, rhythm will be chaotic and wavy, and unmeasurable, and heart rate will be unmeasurable. P wave QRS complex will be absent, and typically this chaotic wavy line with varying amplitude will be defining the characteristic of VF. This is ventricular tachycardia. So ventricular tachycardia, rhythm is regular and heart rate will be typically more than 150. P waves will be absent and QRS will be wide. This is AV dissociation or third degree heart block, where rhythm may be regular or irregular, but atrial and ventricular rhythms will be dissociated from one another. So this is first degree heart block, where you see the PR interval will be prolonged, the QRS will be normal. First degree heart blocks are due to slowed but not blocked conduction through AV node. So next we will go to EtCO2 or capnography. There are two types of EtCO2 monitoring, mainstream or side stream. Where mainstream, the expired gases pass through the center. Side stream, expired gases are aspirated from fine tubing to analyzing chamber. So what are the uses? As previously explained, it is used for confirmation of ET or LMA placement. It helps in diagnosis metabolic, respiratory or hemodynamic events. It gives you information on respiratory rate, breathing pattern and ET tube patency, ventilatory disconnection, malfunction and exhaustion of CO2 absorber. So this is normal capnograph, where there is a phase 1, phase 2, phase 3 is the plateau phase, and phase 0 is fourth phase. So the phase 2 is expiration, this is plateau, and this is inspiration. So normal value is around 35 to 40. It has a gradient of around 5 to 10 between EtCO2 and PaCO2. So this is mainstream sampling, where the CO2 is in the circuit, and this is side stream, where sampling tubing aspirates from the circuit and analyzed on the display monitor. So the disadvantage of mainstream, it has a weight, and the side stream it requires sampling and there is lag period. So these are some of the abnormal capnographs which you can see, where there is sudden loss of waveform, which can be due to ET tube disconnection, dislodgement, kinked and obstructed tube. Decrease in EtCO2 can be due to leak or tube movement in hypopharynx or partial obstruction. Then CPR attempt, minimum it has to be around 10. Sudden increase in EtCO2 can be due to return in spontaneous circulation. This shark fin pattern is seen in asthma or COPD. Hypoventilation is seen as decreased rate, hyperventilation increased rate, and there is decreased EtCO2 in apnea or sedation. Then along with CO2, we measure other gases on monitor. As you can see here, sevoflurane, oxygen, nitrous. We can see on the monitor the respiratory parameters. Its EtCO2 is 23, respiratory rate is 16, and inspiratory CO2 is 0. When it is more than 5, we kind of have suspicion of exhaustion of our CO2 absorber. Then what are the advantages? It ensures adequate pre-oxygenation, detects leak in the system. In combination with EtCO2, it detects it helps in venous air embolism, uptake and elimination of anesthetic agents, and assessment of prolonged emergence from anesthesia based on quantity of residual anesthetic agents. Along with that, we see the respiratory mechanics on our monitor. This is our workstation, as we have seen in previous presentation, where we can see the compliance with pressure volume curve or flow volume curve. There are different loops which you can see, where we have respiratory respiratory values here: peak airway pressure, plateau pressure, mean airway pressure, the expiratory tidal volume, minute ventilation and rate, and FiO2. So all this helps us in managing the respiratory system or ventilation in the anesthetized patient. Then we have cuff tube, where we monitor the cuff pressures in prolonged surgery. where it can increase during the day. So it is kept between 10 to 12 centimeter of water in younger children. So temperature monitoring forms integral part of anesthesia, especially in infants and neonates. Core and peripheral sites are seen. Core are distal esophagus and nasopharynx, and peripheral sites are in axilla or skin temperature is seen. So here you can see the two temperatures which are similar. It is upper one is core and lower one is upper one is nasopharyngeal and the lower is skin temperature. So target temperature is around more than 36 to avoid any complication. And in neonate surgeries, we keep the OT temperature about 25-26 degrees to avoid complications. And it is important to monitor to avoid hypothermia. Also, we kind of modulate temperature like in cardiac surgeries, we give hypothermia, and SSCPs, we go down to 18 degrees. Then we monitor depth of anesthesia. So this for depth of anesthesia, what we use is known as BIS monitor, which is a number which has arrived from processed EEGs and Fourier's analysis, where we get the value. The sensor is attached to the forehead of the patient and it is connected, and the value is seen on the monitor, and processed EEG is down. So it ranges from 0 to 100, where anesthesia range is 40 to 60. It is mainly used in complicated procedures. We used more it in we used it in more in neuroanesthesia and epilepsy surgeries. So this is this procedure we did in last week, where we operated a cervicothoracic neuroblastoma, where we monitored it with BIS and neuromuscular monitoring for recurrent laryngeal nerve. Other monitors are entropy and Massimo SedLine, which is seen in this picture side. So it is recommended more for pediatrics, because pediatric the data in BIS is more on adult focus. Massimo SedLine is used for pediatrics. Then neuromuscular block monitoring agent. The recommendations are coming here. It should be used routinely in pediatric patients where relaxation is used. It is used for monitoring neuromuscular blocking agent and its reversal. The type of stimuli given are single twitch, train of 4, and PTC, post-tetanic count. Train of 4 is the gold standard, where 4 stimuli are given of 2 Hz, 0.5 seconds apart. So here we can see it in young small infant, the 2 electrodes are placed. The distal is negative and proximal is positive. This is the kind of reading which we get on these four responses come from 1 to 4. As you can see, the third one, there is complete block, then deep block, moderate block, and then complete recovery. So top ratio is ratio between first and fourth stimulus response. If it is more than 9, there is adequate recovery. And after complete block, there is post-tetanic count is given. If the post-tetanic count is 1 or 0, the 0 to 1, the block is deep to complete, and then it increases. Then we go towards hemodynamic monitoring, which is very important in anesthesia. The objective is optimize tissue perfusion, maintain adequate oxygenation, and prevent organ dysfunction. So as you can see, perfusion and oxygen delivery is the major objectives in hemodynamic monitoring, which depends on vascular resistance, mean arterial pressure, cardiac output, which cardiac output depends on stroke volume and heart rate, and oxygen delivery depends on arterial oxygen content. So why it is important in pediatrics? It has fixed stroke volume. Pediatrics have fixed stroke volume, immature contractility, higher baseline heart rate, dependence on preload, and there are congenital heart rates. So they are susceptible for dehydration, hypothermia, electrolyte imbalances. Baseline compensatory mechanisms are often maxed out in pediatrics. So we'll start with blood pressure monitoring. So NIBP and invasive blood pressure monitoring. NIBP, important things is proper size cuff has to be used from neonate to the adult, and the limitations are limitation in accuracy and during rapid changes and arrhythmia Also, during major losses, it is less reliable. So arterial line gives you continuous real-time monitoring. Vasoactive drug titration can be done. Severe shock states, it is very useful. It helps in blood sample, frequent blood sampling. So these are the type of catheters which we used in our routine practice, and this is the preparation. This is how the arterial blood pressure waveform looks. It has a upstroke, downstroke, and a dicrotic notch. It is divided into systole and diastole. The shaded parts shows you stroke volume, and the full area under curve is mean arterial pressure. The difference between systole and diastole is the pulse pressure. These are the characteristics waveform in different kind of pathological condition, where you can see aortic stenosis with reduced upstroke. In AR, there is bifid waveform, and as the SVR decreases, the dicrotic notch falls down, and high SVR dicrotic notch is upwards. Also, when we go from center to periphery, the upstroke increases and the dicrotic notch is down. So square wave test is important in assessing your arterial line waveform. You have to pull the string and release it, and then you have to see the upstroke before any arterial waveform. If it is 1 to 2, it is normal. Overdamped if there are less, and underdamped it is more than 2 to 3. So these are the reasons why you get overdamped or underdamped, and you have to rule it out. Like overdamping is seen in soft and compliant tubing, blood clot, air bubble, catheter kinks, and numerous connection. Underdamping if it is long and stiff tubing and transducer with stiff diaphragm. So dynamic parameters in pediatric population used from arterial waveform are pulse pressure variation and stroke volume variation. It is variation in arterial pulse pressure during the respiratory cycle. So if it is more than 10 to 15, the kid will be more fluid responsive. So what are the limitations? It is variable with high and variable heart rate. Chest wall compliance, tidal volume requirement is more than 8 ml per kg. It varies with intracardiac shunt and RV dysfunction. It is not reliable. CVP, it estimates the right atrial pressure, which is determined by interplay between intravascular volume, right ventricular function, and intrathoracic pressure. It can be correlated with the ECG, where there are 3 waveforms, A, C, V, and 2 downstrokes, X and Y. What are the indications? Reliable vascular access, central line insertion. For central line insertion, I'm talking about reliable vascular access, fluid management, advanced therapies, and measurement of SCVO2s. So, what is the critical limitation? Is that the CVP is a static value is unreliable. It is confounded by mechanical ventilation, ventricular compliance, intra-abdominal pressure, and tricuspid wall disease. So trend of CVP value is important rather than single CVP value. So what is SCVO2? It is surrogate marker of global balance of oxygen delivery and oxygen consumption. I will discuss with regional oxygen saturation. I'll discuss later. So it gives you idea of a global oxygen delivery and consumption. So SCVO2 provides earlier warning sign of body oxygen needs are not met. So if it is more than 75, it is normal. If it is less than 25, there is cellular death. So it should, if it is between 30 to 50, that is exhaustion of extraction and beginning of lactic acidosis. So low SCVO2 is seen in low SCVO2 is seen in increase of low oxygen increase oxygen delivery. Arterial saturation is if arterial saturation, you have to see secure airway and adequate ventilation. SCO2 more than 95. Hemoglobin in shock, transfuse PRBC, and target HB of 10. Then we have to, if there is low SCO2, and we have to optimize the cardiac output. If preload is less, we have to administer fluid. Contractility is less, start inotrope. And after load, we have to, if the patient is hypotensive, start vasopressor to restore perfusion pressure. And then if we have fever, we have to control fever and ensure adequate sedation and consider neuromuscular blockade. Next is cardiac output monitoring, which is a product of heart rate and stroke volume. So as you can see in this diagram, cardiac output falls far earlier, and arterial pressure starts dropping when the cardiac output is already 30 to 40% low. So what are the methods of monitoring? There are invasive, minimal invasive, or non-invasive. Thermodilution, PICO, LIDCO, and flow track, esophageal Doppler, non-invasive bioimpedance, and transthoracic echocardiography. So pulse contour analysis, here there is one arterial line and one central line, where sample is taken from central line and one arterial line, and the difference in temperature is calculated, and it gives you cardiac output. Flow track uses pulse contour analysis, single arterial line, and there is no external calibration needed. It is recommended above 12 years of age. So these are the flow tracks and junior sensors and hemosphere monitor, which gives you systolic, diastolic, and mean blood pressure, cardiac output, stroke volume, SVR, stroke volume variation, pulse pressure variation, and pulse rate. Next is hypotension predictive index. It utilizes advanced algorithm and machine learning techniques to analyze real-time hemodynamic data and generate predictive indicators of impending hypotensive events. It displays the values ranging from 0 to 100, with higher values indicating likelihood of hypotensive event. So it is updated every 20 minutes. So it gives you prediction of hypotension before it happens. So that's where the monitoring is going now, where we are anticipating the event. It's not moving forward. So this is the monitor which gives you all kinds of hemodynamic values like preload, contractility, afterload, hypotension predictive index. Then we have electrical cardiometry, where a low amplitude, high frequency electric current is sent to the thorax, and the resistance it faces is measured. So it assumes that characteristic change in the thoracic conductivity during each cycle is due to the change in orientation of RBCs when it is subjected to pulsatile blood flow. So it differentiates the flow of RBCs during systole and diastole at aortic valve, and calculates the change in resistance and the laminar and turbulent flow, and it gives you cardiac output non-invasively. So it gives you blood flow, contractility, blood pressure, fluid status, vascular resistance, and oxygen. So it is recently been seen that it can be used in pediatric patients also. Tissue oximetry, as we saw SCVO2 being an invasive measure of global oxygens, NIRS monitor gives you non-invasive measurement of the regional oxygen saturation of the brain and various places. Places it can be done, like flanks and kidneys and everywhere. So this is non-invasive tissue oximetry, which is very important in complex and prolonged cases. So here we can see there are these channels which are attached to forehead, and these sensors are attached to forehead on both sides, and the readings are seen on the monitor. So we have to, the difference, the target is it should be more than 40 to 60. The drop should not be more than 20% of the baseline. The difference between the two sides of the reading should not be more than 10%. So how to increase this cerebral oximetry? You have to increase the oxygen, increase cardiac output, increase mean arterial pressure, increase sedation so that there is decreased consumption, decreased temperature, increased hemoglobin, and increased saturation. Urine output is also important. You monitor for our surgeries, during which we have to maintain it around 1 to 2 ml per kg. It indicates adequate renal perfusion and hydration. Blood gas, yes, it is a point of care monitor for us during surgery. It is important in prolonged surgery due to rapid physiological changes that patient undergoes. It gives you idea about lactates, electrolytes, and blood gas exchange. It helps in glycemic control. In neonates, glucose level should be more than 45, and in older children it should be more than 60. Lactates should be less than 2. Echocardiography is another quick, cost-effective, non-invasive, portable, and relatively easy. It has a learning curve. It requires training for cardiac monitoring. For transthoracic, we have 4 views: subcostal, parasternal, apical, and suprasternal. It gives you idea about LV function with pump performance, myocardial contractility, and contractile function. With eyeballing, decrease in more than 30% of radius is normal, 10 to 30% is mild dysfunction, and less than 10% decrease is severe dysfunction. The indicators for LV functions are fractional shortening, ejection fraction, and Doppler assessment of cardiac output. So parasternal long axis view, here we can see the fractional shortening, which we can put M mode and see. Then at the level of mitral leaflets, then Simpson method for ejection fraction in apical 4-chamber and 2-chamber. Next, we will see the diastolic dysfunction, where pulse wave Doppler is put across mitral wall leaflets, and E by A ratio is calculated. Normally, it is 1 to 2. There are 3 stages of diastolic function, which is beyond the scope here, and myocardial performance index, which is independent of load independent and heart rate independent, which is calculated. Then there is Doppler measurements of cardiac output. Here we have seen a parasternal long axis. We have to get the LVOT diameter, and we take the LVOT BTI in apical 4-chamber view, and it gives you cardiac output. Right ventricular function assessment is done in apical 4-chamber parasternal short axis view, where we can see the enlargement of RA and RV and D-shaped ventricle, and which is RV dysfunction and shows pulmonary hypertension. Also, if there is dyskinetic movement of interventricular septum. Then we can assess volume, IVC assessment, subcostal view, IVC collapsibility / distensibility index, which can be seen. If it is more than 12% change, patient will be fluid responsive. Also, LV end diastolic area gives you status of volume status of the patient. LVOT time, velocity time integral index also is used, where VTI is put across LVOT and pulse wave Doppler, where if it is more than 12% variation, it indicates hypovolemia. In short, I will tell you about transesophageal echocardiography. These are the type of probes, where there is adult, pediatric, micro, pediatric, and micro probe, 3D adult, pediatric, and micro probes. It is put in esophagus behind the heart, and the echocardiography is done at 4 levels: upper esophageal, mid esophageal, and transgastric. And there are 20 standard views. It is very useful in intraoperative during cardiac and non-cardiac procedures, but it requires general anesthesia. And absolute contraindications are coagulopathy and varices, where it can't be used. So thank you. Here we can see the whole Brazilian football squad, which is talented and just like our monitor, but it has to be used properly by their manager. Thank you.
Thank you, Dr. Vaibhav, for that in-depth knowledge about what goes into monitoring of pediatric patients during anesthesia. Uh, Next up is Dr. Minoti, who is a fellow at Anesthesia Department. She is doing fellowship in pediatric anesthesia, and she'll be talking about pain management in pediatric patients. Over to you.
Good evening, everyone. My topic is the art of pain management in pediatric patients. Margot McCarthy famously quoted saying, "Pain is whatever the person says it is and exists whenever he says it does. But most of our patients are pediatric patients who cannot say where it pains or when it pains. Pain is defined by the International Association for the Study of Pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. In 2020, they revised the definition of pain and explained an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. In 2020, they revised the pain notes, stating pain is always a personal experience that is influenced to varying degrees by biological, psychosocial, and social factors. Pain and nociception are different phenomena. Pain cannot be inferred solely from activity in sensory neurons. Through their life experiences, individuals learn the concept of pain. A person's report of experience as pain should always be respected. Although pain usually serves an adaptive role, it may have adverse effects on the function and social and psychological well-being of a person. Verbal description is only one of the several behaviors to express pain. Inability to communicate does not negate the possibility that a human or a non-human experiences pain. Why is pain assessment important in children? Pain is a common yet often under-recognized problem in children. Up to 80% of hospitalized children reported experiencing pain during their stay, with 66% reporting moderate to severe levels of pain. Anderson et al. Found that 72% of children experienced moderate to severe pain within the past 24 hours, that is, within 24 hours from admission, with 43% reporting additional procedural pain alongside their primary condition. 40% of pediatric patients suffer from moderate to severe pain after surgery. Pediatric patients with the same diagnosis as that in adults receive lesser analgesic doses. The younger the child, the less likely they are to receive analgesia. There are certain pain management myths in pediatric patients, such as neonates do not feel any pain, infants are less sensitive to pain than adults, neonates have no memory of pain. Children will tell you when they are having pain. If a child can be distracted, he is not in pain. Neonates are not able to tolerate the effects of analgesics. Narcotics can lead to addictions in children. Children become accustomed to pain. Why should perioperative pain matter? A perioperative pain is not just discomfort, but a pathophysiological stressor involving multiple systems, such as endocrine system, which causes increased ACTH, cortisol, ADH, epinephrine, norepinephrine, decreased insulin, testosterone, increased gluconeogenesis, hepatic glycogenolysis, hyperglycemia, glucose intolerance, insulin resistance, muscle protein catabolism. Cardiovascular system has increased heart rate, cardiac workload, increased PVR, SVR, increased myocardial oxygen consumption, hypercoagulation, DVT. Respiratory system, decreased flow and volume loops, atelectasis, shunting, hypoxemia, decreased cough with sputum retention and infection, genitourinary, decreased urine output, urinary retention, fluid overload, hypokalemia, decreased gastric and bowel motility, muscle spasm, impaired muscle function, fatigue and immobility, reduction in cognitive function and mental confusion, depression of immune response, developmental, especially important in children, increased behavioral and physiological responses to pain, altered temperament, higher somatization, distress behavior, altered development of pain system, increased vulnerability to stress disorders, addictive behaviors and anxiety, debilitating chronic pain syndromes, sleeplessness, anxiety, fear, hopelessness, and suicidal ideation. What are the barriers to pediatric pain management? As we read earlier, the myths of pain in children, knowledge and training deficits in pain assessment and management, misconception about pain perception in children, organizational and structural issues like staffing issues, lack of institutional policies, limited multidisciplinary collaboration, medication and prescription challenges like pharmacological barriers, parental attitudes, restrictive policies, opioidophobia, communication and information barriers, technological barriers, structural constraints, lack of funding, and more importantly, lack of accountability for undertreatment of pain. child-related problems like different developmental stages with different emotional dimensions. The most common barriers are limited language in young children, difficulty detecting signs and symptoms of pain in different age groups, deciding if observed signs and symptoms is due to pain or other factors, standardizing inter-rater observation, use of culturally unvalidated scale, cultural diversity, environmental and family factors influencing pain, anxiety and fear may mask pain behaviors, multiple available pain assessment scales to choose from. The goals of pain management are four important goals. First, make pain better. Second, make pain understood. Third, make pain visible. And fourth, make pain better. Principles of pain assessment in children. Always remember, pain is subjective. Child's perspective always comes first. Use tools suitable for age and development. Assess pain regularly and document the findings. Consistent use of the same tools supports accurate monitoring, combined with observations of activity, parental report, and environment. The QUEST approach is a strategic and simple approach for pain assessment in children. Q, question the child. U, use age and developmentally appropriate pain rating scales. E, evaluate behavior and physiological changes. S, secure parental involvement. T, take the cause of pain into account. And again, T, take action and evaluate results. Pain assessment tools in children are divided broadly into three categories: self-report tools, behavioral and observational tools, and physiological indicators depending on the age of the child, broadly classified as neonates, infants, school age, and adolescents. Self-report tools can be used in verbal children, namely the school age and the adolescent. Behavior and observational tools are used in pre-verbal infants, cognitively impaired patients. Physiological indicators are supplementary tools, cannot be used for primary assessment. The Von Baker Faces Pain Scale, the Visual Analog Scale, and the Numerical Rating Scale are the ones which are most commonly used self-report tools used in adolescent and school-going children. Behavioral or observation-based scales, the most commonly used are the FLAC scale, the CHIOP scale, the NIPS or the Neonatal Infant Pain Scale, PIP or the Premature Infant Pain Profile, and CRY scale, which is used in neonates for postoperative pain. The FLAC scale has 5 domains, namely face, legs, activity, cry, and consolability, with a total score of 10, with each rated 0 to 2. Cry scale for postoperative pain in neonates, again, 5 domains: cry, requiring FiO2 to maintain SpO2 more than 95%, increased vital signs, expression, and sleeplessness. Revised FLAG scale or the R-FLAG scale can be used in children more than 2 years of age with mild to severe cognitive impairment, example cerebral palsy, autistic spectrum disorder, or non-verbal children, with a total score of 0 to 10. Additionally, it includes behavioral descriptors, example verbal outburst, tremors, increased spasticity, jerky movements, or change in the respiratory pattern. Option for the caregivers to add different behaviors, validated for post-op and procedural pain. Facial recognition. Pain Check is a newer app which can be used for infants. It is a validated medical device for automated assessment of pain in children. It uses 6 facial action units indicative of the presence of pain, mainly brow lowering, wrinkling of nose, lip corner depression, mouth stretch, parting lips, and closed eyes. Physiological indicators of pain are heart rate, blood pressure, oxygen saturation, used as supportive data, not as standalone assessment. Behavioral signs include facial grimacing, frowning, crying, whining, or sudden silence, withdrawal or guarding, restlessness or stillness, changes in sleep and eating patterns. Pediatric multimodal analgesia is a combination of pharmacological as well as non-pharmacological methods, whichever optimizes pain relief and decreases adverse effects. The most common are the basic analgesic paracetamol, NSAIDs, COX-2 inhibitors, along with opioids, weak opioids like tramadol, and stronger opioids like morphine, fentanyl. Regional anesthesia, neuraxial, caudal, epidural, peripheral nerve blocks, intrathecal pumps, along with adjuvants, alpha-2 agonists like clonidine, dexmedetomidine, gabapentinoids, TCAs, NMDA antagonists, sodium channel blockers, along with the non-pharmacological integrative therapies like mind and body techniques, hypnosis, biofeedback, acupuncture, acupressure, aromatherapy, psychological training like cognitive behavioral based therapy, child life services, rehabilitation with exercise, physical therapy, occupational therapy, along with trying to normalize their life with school attendance, sports, and exercise with spirituality. The pharmacological pain relief can be given by different routes. First one is the topical or the local. The example, EMLA cream, ethyl chloride spray, local infiltration with lignocaine or bupivacaine. Systemic, enteral can be oral, rectal, or buccal. Parental, IV, which means bolus infusion, patient control analgesia, nurse control analgesia, intramuscular, subcutaneous, intranasal, inhalational, example, nitrous oxide, which is used for dental procedures, regional anesthesia, central neuraxial blockade, spinal anesthesia, epidural, caudal, or peripheral nerve blocks. The WHO pain ladder broadly classifies pain into mild, moderate, and severe and advises treatment accordingly. Mild pain, non-opioids like paracetamol, NSAIDs, non-COX-2 inhibitors, ibuprofen, diclofenac, ketorolac, COX-2 inhibitors, celecoxib, paracoxib. Step 2 is moderate pain or mild pain unrelieved by the previous step. It involves weak opioids like tramadol, codeine, or lower dose of the stronger opioids like morphine, fentanyl, oxycodone, along with the non-opioids, with or without the adjuvants like gabapentinoids, which include gabapentin, pregabalin, tricyclic antidepressants like amitriptyline, NMDA antagonists like ketamine, alpha-2 agonists, clonidine, dexmedetomidine, steroids, muscle relaxants, and antispasmodic. For severe pain or moderate pain unrelieved by the previous steps, higher dose of opioids, IV morphine titration, PCA delivery, or continuous infusion of IV opioids with or without the non-opioids or adjuvants. The dosing is also advised by WHO. It should be by the clock. Scheduled dosing is more effective than pro rata basis. Choose frequency based on the duration of action. By the mouth, prefer oral route. If not feasible, use least invasive options. Avoid IM administration. By the ladder, stepwise use of non-opioids, mild opioids, and then stronger opioids as adjuvant as and when needed. Patient control analgesia in pediatric patients, this can be used for adolescent patients, allows the patient to titrate the analgesic to their desired effect of analgesia. The rationale being that pain is a highly subjective and personal experience with variability in opioid metabolism. Removes any delay of analgesic delivery in comparison to an as needed order that requires a nurse to be contacted, then wait for the drug preparation and administration. Studies have shown that overall opioid consumption is lower and patient satisfaction is higher with PCA, fewer adverse effects such as sedation, nausea, and vomiting. Regional anesthesia involves neuraxial blocks like spinal anesthesia, epidural block, caudal, lumbar, thoracic, or combined spinal epidural, along with the peripheral nerve blocks, which are scalp blocks, thoracic nerve blocks, abdominal wall blocks, pudendal, paracervical blocks, or IV regional analgesia. Neuraxial anesthesia in infants offers significant advantages over general anesthesia in certain group of patients like preterm patients. Caudal blocks may be superseded by ultrasound-guided peripheral nerve blocks, many of which offer superior block quality and longer duration of action. Pediatric thoracoabdominal anatomical plane blocks provide satisfactory perioperative analgesia for many surgeries. Caudal anesthesia is basically infiltration, injection of local anesthesia into the caudal space with a dose of 0.5 ml per kg at the sacral, 1 ml per kg for sacral up to the lower thoracic levels, and 1.25 ml per kg for sacral up to the mid thoracic level. Epidural anesthesia, usually in children given after induction of general anesthesia, can be a single shot or continuous catheter infusion with or without additives. Peripheral nerve blocks. These are the type A blocks, which are important and the most common and effective in pediatric patients. Caudal block, axillary nerve block for the upper limb, popliteal, sciatic, and femoral nerve block for the lower limb, abdominal wall block like rectus sheath, and lateral quadratus lumborum block, and a dorsal penile nerve block. Most of the peripheral nerve blocks, specifically in pediatric patients, are given under USG guidance. Non-pharmacological methods, the psychological approach, sharing information about procedures, explaining the procedure to the patients themselves, can be done in slightly elder children. Distractive techniques, active distraction with interactive toys, virtual reality, controlled breathing, guided imagery, and relaxation. Passive distractions, auditory distraction with music or audio distraction with a telephone or a mobile phone. Non-distractive technique, transcutaneous electrical nerve stimulation, cognitive behavioral therapy, acupressure, cryotherapy and heat therapy, traction and bracing. Child Life Services are a group of specialists which focus on providing psychosocial, sibling, and family support to children requiring longer hospital stays. Music and art therapy is also helpful in patients who have chronic pain for relieving pain as well as expressing pain. So the take-home messages: use multimodal and individualized pain strategies, follow WHO analgesic ladder for escalation, reassess route, switch to oral when possible, dose safely, adjust for age, weight, and comorbidities. Opioids to be titrated, monitored, and minimize adverse effects. Adjuvants can enhance relief and reduce opioids. Watch for contraindications and interactions. Involve pediatric pain or anesthesia team early. Thank you.
Thank you, Dr. Minoti, for beautifully explaining the various aspects of pediatric pain management. Next, we have Dr. Lopamudra Majhi, Consultant Pediatric Cardiac Anesthesiologist. She will be talking about the nitty-gritties of pediatric cardiac anesthesia.
Thank you, Priyanka, for the introduction. So, when we think of cardiac surgery, we usually think of cardiac surgeon, complex procedures, or machines. But in pediatric cardiac patients, the most important, which affects the outcome, is very little visible. That is the physiology, which is managed time to time. Today, in this lecture, I'll walk you through in next 20 minutes how cardiac anesthesia actually matters of the heart, where the risk lies, and how you people are affecting the outcome. So why I chose this title, Matters of the Heart. So whenever we think of heart surgery, it is different from any other organ which we operate because it involves a moving vital organ and which cannot be stopped. And in children, the hearts are not only small, they are often structurally abnormal. And there you will find shunts, you will find abnormal structures, mixing of the blood where it should not mix, completely bypassing the lungs. You will find all these physiologists. So the cardiac anesthesiologists are actually not the anesthesiologists, they are the physician of physiology. So, before we should know how common this pediatric heart disease is. So, it is usually very common. You will find 8 to 10 per thousand live births. And so, in your routine practice, you will encounter one of these childs, whether the congenital heart disease is diagnosed or not. And now in this setting in the India, there are many largely untreated populations. So this increases surgical risk and the anesthesia becomes more challenging. For these patients, surgery and anesthesia are not optional, they're actually life-saving. So we should see how the cardiac anesthesia evolved slowly. Earlier, heart surgery was impossible because we cannot stop the heart, and the moment heart is stopped, life is stopped. So actually, heart surgery developed by the development of heart-lung machine, and in 1950, John Gibbon developed this cardiopulmonary bypass. So the circulation and the physiology of the heart is managed by the machine. Then only the cardiac surgery started. As the cardiac surgery started, the anesthesia cannot be routine. So anesthesia for there are need of managing the circulation, organ protection, temperature, anticoagulation. So cardiac anesthesia become evolved, and there comes the special discipline like cardiac anesthesia. So coming why cardiac anesthesia is different. Cardiac anesthesia is never a drug driven anesthesia, it is always a physiology driven anesthesia. We managed that tiny physiology. We try to balance between pulmonary and systemic blood flow because whatever we give, our drugs, ventilation, depth of anesthesia, try to change all this physiology. And then many children have abnormal connections like shunts, blood may mix, bypass the lungs, or overload one side of the heart. So all these things we try to manage by managing the physiology, and any small errors can cause major instabilities. So to maintain that physiology, we need advanced monitoring. As my previous speaker, Dr. Vaibhav has told already about this, but our goal is not only to get those numbers. Our goal is to, although the numbers are fine, there should be organ perfusion and organs are getting oxygenated. So after that, let's see how these monitors are helping us in the operation theatre. Our work starts long ago before the patient comes to the operation theatre. We optimize the hydration, we correct anemia, infections, and electrolytes. And here, basically, the induction was planned based on the cardiac lesion. Whatever during induction, if there is a small changes in the blood pressure in other anesthesia, that may be okay, but this is not okay in cardiac anesthesia because by decreasing blood pressure or any change in the ventilation can drastically alter the blood flow. So here the induction is slow, controlled and tailored, and it is not routine. Once patient is induced, next is to initiate the CP bypass. CP bypass is the machine which momentarily, temporarily takes over and provides circulation and oxygenation to the patient, and so that surgeon can operate on the heart during that time. And we manages the temperature, anticoagulation, perfusion, and organ protection. And all these things can be done safely with the coordinated action between surgeon, perfusionist, and anesthesiologist. going on CPB is not challenging. The most challenging portion in OT is separating from the bypass. Separating means the heart should be ready to take over all the circulation once again. So before that, we prepare the heart by assessing the heart function, adjust the drugs, correct acidosis, and support the circulation immediately or by gradually. So even though surgery is done, the physiology is still fragile and it continues in the cardiac ICU as well. So that's why our role increases beyond the OT that brings us to manage the ICU. So in ICU, the ventilation is not about just providing the oxygen. It directly affects the blood flow to the lungs and the heart. And if improper ventilation is happening, that can worsen your heart function or pulmonary pressures. So next, many patients, these children need multiple infusions to support the heart contraction, to control the blood pressure and reduce the stress on the heart. And here the goal is not to keep the blood pressure high, but to provide the adequate organ perfusion. And the most common problems we watch are low cardiac output, arrhythmias, pulmonary hypertension, bleeding, and organ dysfunction. And this can evolve rapidly and sometimes within minutes requiring ECMO supports. So beyond, our work doesn't finish in only OT or ICU. It goes beyond like cath lab, CT, MRI, and in cath lab we do balloon dilatation, stent placement, device closures, diagnostic CAS for operability. And during this procedures, the physiology is same, although it looks like less risky, but you have to keep that vigilant eye on that physiology. And once, if there is, like while doing any balloon inflation or device deployment, that can be instantly obstruction of the circulation. So you have to be very cautious at that moment. In CT, MRI, my next speaker, Dr. Harick, will talk about more on this. But when we are giving sedation to this cardiac patients, this sedation cannot be a simple sedation because by giving simple sedation, it quickly affects the breathing and circulation, and any hypoventilation, airway obstruction, or breath desaturation can rapidly destabilize the cardiac physiology. So what it appears as light sedation can suddenly become a cardiovascular emergency. So all these things requires not only one specialist, it requires team approach. And it is always a coordinated program. Whenever child comes with heart disease, outcomes doesn't depend only on the surgery or the surgeon, but it always depends how well the cardiologist, anesthesiologist, ICU, and support services work together. This is the team working at SRCC. And this article, Cry of the Children, beautifully describes the development, the progress of congenital heart surgery in India. The cry, in essence, cry says the need of surgery, urgent surgery in such patients. And the journey shows how we have reached to provide our successful outcomes so that you people are finding them in adulthood in your OPDs. But the major hurdle, if you ask me, is the manpower. Although the current numbers of cardiac anesthesiologists practicing in pediatric cardiac is in India, it's 100, where the required number is 1,000, which is 10 times. Requirement is 10 times. Similarly, other things like centers, intensivists, nurses, pediatric cardiac surgeons, as you can see, so many, like we are very less in number, whatever is the requirement is there. So, so next comes why you people should care. Let me give you one child scenario, one case history you may recognize. A 3-month-old infant has been brought with poor weight gain and repeated chest infections. Feeding takes long time, the baby sweats while feeding, and oxygen saturation is borderline, but not alarming. And each visit is treated as infection or nutrition. No one is wrong here, actually, but something is missing. So, what was actually happening? There was an undiagnosed congenital heart defects, and by the time the child reaches us, the pulmonary pressures were already high, which increases the risk of surgery and the ICU care and the outcome. So, what are the red flags? You see it in daily practice. Poor weight gain or failure to thrive despite adequate feeding. There are recurrent chest infections which are very slow to recover, and any unexplained desaturations or cyanosis, especially during feeding or crying, or any syncope or easy fatigability is usually never normal for a kid. You people may not operate, you people may not provide anesthesia, but you can decide when you can send those kids to us. So, how you are going to change it? By doing early suspicion, by thinking that heart disease may be there, it can save weeks or months, and by doing timely referral before any infection, malnutrition, or pulmonary hypertension sets in, decreases the risk for that kid. And by preventing infections, you are stabilizing the fragile cardiac physiology. And here, in these kids, vaccination and nutrition, they are not only supportive measures, they are rather life-saving interventions. So when all these things fall into pieces, how it looks like this is the cardiac program we are running at SRCC. Here, till now, we have done 6,000 plus congenital cardiac surgeries with stable and reproducible outcomes, and the spectrum being from fragile neonates to the adults with congenital heart disease. And this is not because of only one person, this is because of a coordinated multidisciplinary pediatric heart program. So at the end, I want to take this take-home message. Usually in children with heart disease, outcomes are not determined by one moment or one person. Rather, they are determined by how well physiology is protected from the first consultation to the ICU. Little things like early diagnosis, early referral, early surgery, and early management of the physiology, correct management of the physiology in the ICU changes the outcome. Thank you for your time and patient hearing.
Thank you, Dr. Lopamudra, for that strong message that you have put out, that we collectively have to go from the problem to power. And that glimpse into the pediatric cardiac anesthesiologist and their role as the perioperative physician. Next up is Dr. Harick. He will be talking about what goes into the sedation process or the anesthesia process in the outside the OR, the know-how of non-operating room anesthesia.
So, I promise this is going to be a last talk, and I'm going to talk about pediatric non-operating room anesthesia, that is NORA. about its challenges, safety, and procedural specifics. So the roadmap would include how do we define NORA, what are the pre-anesthetic evaluation and NPO guidelines, discuss monitoring standards and equipment, and analyze specific considerations for radiology, gastroenterology, pulmonology, cath lab, dental chair, etc. So NORA basically means administration of sedation or anesthesia to patients undergoing painful or uncomfortable procedures at off-site locations. So off-site locations basically include all these radiology, gastroenterology suites, bronchoscopy suites, cath lab as discussed with Dr. Lupa. And pediatric population is the subgroup at the highest risk level and the lowest tolerance for error. So how did we go from giving anesthesia in the OR to outside the OR? So there is always increase in demand for diagnostic and therapeutic procedures outside. Children, they often require deep sedation or general anesthesia for procedures. Adult tolerate very well in awake, example MRI. The goal is to have a motionless analgesia, anxiolysis, and physiological stability. And NORA represents a significant percentage of pediatric anesthesia volume. At our setup, we do at least 8 to 10 cases a day, combining all MRI, CT scan, and cath lab, which almost is as much 50% of our practice. So what is the remote challenge? So the environment starts with environment. It is unfamiliar, often small, dark, crowded, and there is equipment fitted into a very small space. You can barely move around. The ergonomics are very poor, and the access to the patient is not easily available. Normally, as anesthetists stand on the head end, we have an IV with us. The airway of the patient is very next to us, and we feel very comfortable and in control. But as far as say MRI or CT or cath lab is concerned, we are standing very far away from the patient. Then next is resources. Help is often very far away. Anesthesia carts may not be up to the mark. Other equipment may not be up to the mark. Most what commonly what happens is the oldest machine, anesthesia machine, is probably there in one of these remote locations. For MRI, you need specific different type of equipment which is MRI compatible and not made up of ferromagnetic material. So all these problems cause either there is a limited stock available or if it is an old machine which is available. And also the culture. So the OR staff is quite familiar with how the process of anesthesia is. These remote locations we know may have the staff which is equally experienced. Also, what normally happens is that there's a difference. Say you come in to do an MRI, normally what the parents think is that oh, it's just an MRI or just a scan. What happens is the baby is not stable enough or keeps on moving and we need to give sedation. So as far as sedation is concerned, it is almost as similar to what we do in the OT. And normally they may not be fasting. So our radiology colleagues would come and say, okay, just an MRI, the fasting is not adequate. So that needs to change and it's a very big problem. Then coming to preoperative assessment, we focus on the airway history, sleep apnea, recent URI, previous sedation issues. So a lot of kids nowadays come with runny nose. The problem is if there is a runny nose, there's a risk of bronchospasm and laryngospasm increases 5 to 10 folds. So normally what traditional teaching was is if the child has an URI, you postpone the procedure by 2 to 4 weeks. But it may not be possible because the child will have a URI every 4 weeks or 6 weeks. So we have a certain red flags. That is if the child has fever, productive cough, lethargy or wheezing. In that case, we definitely postpone the child. Otherwise, we do explain the risk to the parent and we go ahead with the procedure. Then if there is an airway history of sleep apnea, so we look for history of snoring, ask about pauses or gasping. OSA patients particularly are very highly sensitive to opioids and sedatives and they can rapidly desaturate. Then being a pediatric hospital, we do get a lot of patients where they've gone to MRI, have an MRI at other hospital, but the pediatric specialist anesthetist is not available and they come to us. They usually are trisomy patients. They can have other metabolic syndrome disorders where the tongue is too big and the baby is just snoring. Baseline saturation is at 90, 92. Patient can come with PA Robin where there is micrognathia and the airway may be difficult to manage. So we do get a lot of these patients who have then also the biggest factor is the parental anxiety. So what we do is whenever the parents come in thinking, okay, it's just an MRI, just a CT or an ultrasound, and when we go and explain them that, okay, the child may require sedation because he's not cooperating or obviously kids will not cooperate. Okay, and these are the things when we go and take the consent, they're really anxious. Okay, oh, all these things will have to be done to their child. So for MRI or CT scan or any sedation procedure, the fasting guidelines are the same as for a baby coming for a surgery, and these have to be adhered to. So the clear liquid is 2 hours, breast milk is 3 hours, infant or formula or light meal is 6 hours, and fatty or solid food is 8 hours. And gastric emptying may be delayed in cases of trauma or acute pain. Then coming to monitoring standards, again, the monitors at this remote location have to be of the same standard as in the OR. It is a non-negotiable. They require oxygenation for pulse oximetry, capnography for ventilation, so for circulation, ECG, NIBP, and temperature. Then coming to pharmacology, so the most common technique is totally intravenous anesthesia, which is propofol based. It has a rapid onset and a rapid offset. Then we have a newer agent called dexmedetomidine, which provides sedation with minimal respiratory depression. It is very useful for airway procedures. Then ketamine is useful for patients, particularly cardiac patients, and also it helps in maintaining spontaneous respiration. But the problem with ketamine is there are a lot of secretions. And then sevoflurane, if you have a compatible machine, can be useful for inhalational induction. Then coming to MRI, particular hazards are so MRI basically is a huge magnet. The strength can range from 1.5 to 3 Tesla. Hazards are a projectile effect. So if you, by chance, you all must have heard stories of oxygen cylinders getting pulled into MRI machines. So basically these become projectile because any ferromagnetic substance in and around the MRI coil, it can pull it towards itself. And also the monitoring wires, basically your ECG wires, if they are coiled, it can cause burns. And also MRI machine makes a lot of noise. So majority of all the patients need to wear ear protection. As I said before, equipment needs to be specialized, including your wheelchairs and your trolleys, and all are made up of materials which are not ferromagnetic. And the monitor which you see is also a wireless monitor. So this is one of the ways we do MRI. All the patients are spontaneously breathing, but as I said, we get a lot of patients who are syndromic, whose airways may be difficult, and the moment we give them sedation, they start snoring. What happens is with snoring, the head kind of vibrates, and the MRI scan doesn't come good. So this is one of the technique which we use. We just strap the chin up to the coil and kind of opens up the airway, pulls the tongue forward, and the turbulence is gone. Certain times we may have to use take over the airway. In that case, a laryngeal mask or an ETT can be used. Laryngeal mask is quite common as we can still maintain spontaneous respiration. ETT is only used for rescue or emergency. And second is the child, since the MRI, in the MRI, the child completely goes inside the scanner. So we need long extension tubings for IVs and breathing circuits. This is another kid with A-rhinia coming for CT. So as compared to MRI, CT uses ionizing radiation, whereas MRI uses magnetic imaging. But the upside is it is extremely fast, doesn't last more. The CT scan probably gets over in 3 to 5 minutes. So anesthesia for very small babies, mild, very minimal sedation, or if you simply feed them well and wrap them, they will not move. They usually don't require any intubation. The only caution is a contrast dye reaction during kidney injuries. Coming to gastroenterology, it can be divided into upper, where the concerns are shared airway, and endoscope usually obstructs the oral cavity. Colonoscopy, the stimulation is variable. It can be painful during insufflation and during turns. Positioning is usually lateral decubitus or prone. Coming to gastroenterology, normally our airway management would be natural airway, spontaneous breathing kit with oxygen cannula or mask. It's a TIVA based again. Intubation is required if there is risk of aspiration like active GI bleed or foreign body removal or structure dilatation. And complication like laryngospasm is high due to secretions and scope manipulation. Then coming to colonoscopy, rapid insufflation can cause vagal reflex and bradycardia. And also if there's a lot of insufflation, it leads to abdominal distension and inhibits gastric distension. It causes a sprinting effect, and the patient finds it difficult to breathe. And as far as volume status is concerned, for colonoscopy, all the patients undergo bowel prep, which causes significant dehydration and electrolyte shifts. Coming to bronchoscopy, indications usually are stridor, foreign body aspiration, airway, malacia, and lavage. So the conflict is again us and the pulmonologists are competing for the same airway. The goal for anesthesia for bronchoscopy is to suppress cough reflex while maintaining oxygenation and spontaneous breathing. So again, anesthesia technique, the best is propofol based EVA. Here additionally what we do is we spray the airway, we anesthetize using lignocaine, maximum being 5 milligram per kg to prevent laryngospasm. Spontaneous ventilation is preferred for diagnosing dynamic airway collapse like laryngotracheomalacia and bronchoalveolar lavage. Intermittent apnea and ventilation through rigid bronchoscopy is used for foreign body removal, where we also paralyze the patient. Then coming to cardiac cath lab, I'll just quickly brush through it again. So in preoperative time, we need to know the physiological analysis of the baby coming to cath lab. We need to determine where the shunt is heading, size and mixing physiology. We establish baseline cyanosis and define the target saturations. And if we can, we evaluate the pulmonary vascular resistance, sensitivity to hypoxia, hypercarbia, acidosis. Then coming to risk stratification, high risk are neonate infants, existing pulmonary hypertension, heart failure, and prematurity. And we also look for comorbidities like renal dysfunction because for cath lab procedure, a lot of contrast is injected and can cause kidney issues and airway syndromes. And logistics and safety wise, we do get coagulation profile and renal function done and cross match for high risk cases. And also we plan for critical moments like rapid pacing, balloon inflation, and we ensure emergency readiness for defib, ECMO, or if the child has to be taken up in the OR for open procedure. Hemodynamic goals look very simple on paper, like maintain preload, afterload, and contractility, control PVR spikes, but it's a very dynamic situation and we need to pay a lot of attention on how to go about it. And for diagnostic integrity, we need to coordinate the FiO2 and ventilation with the cardiology team to preserve validity of the shunt measurements. Anesthetic technique sedation is preferred for stable, short, and less invasive cases, and GA for infants, unstable physiology, or long complex interventions requiring immobility. So, and monitoring and access against same as any other standard ASA monitor with capnography, invasive monitoring like arterial line for unstable patients, and pre and postductal saturation for ductal lesions, and vascular access reliable to IVs preferably, and anticoagulation management. Then coming to crisis, two of the most common in cath lab include your arrhythmias, more common during wire manipulation, and pulmonary hypertension crisis. And coming to emergence, we normally extubate only if the physiology is stable and gas exchange is acceptable. Patient is kept intubated if there is significant bleeding, pulmonary hypertension, or hemodynamic instability. The goal is smooth emergence to prevent coughing straining, which increases PVR and bleeding risk. Last is your dental chair. So this is the nitrous oxide cylinder which I was talking about. So nitrous oxide oxygenation, it serves as the following goals. It reduces the fear, anxiety, instills a positive attitude towards dental care, to raise the pain reaction threshold, reduce untoward movement, and to help control a hyperactive gag reflex that can interfere with dental care. And also to provide an amnestic effect, thus creating a more positive outlook towards dental care. So coming to recovery in NORA, we need a dedicated recovery area with trained staff, emergency equipment, and trucks. Modified Altitude score is used to check for readiness for discharge. For OPD patient, we ensure pre-procedure status. We talk about tolerating feeding, no post-operative nausea, vomiting, and maintained vitals. Emergent delirium and hypoglycemia is a real problem, especially if the patient is small and if there is prolonged fasting. Delayed recovery can happen in some kids, say with OSA, who have more sensitivity to opioids or sedative, and obviously we do ensure proper documentation. Coming to common complications, they range from hypothermia in MRI and cath, where the room is kept cold for equipment. Laryngospasm is pretty common with endo and bronchoscopies, where the airway is shared. Bradycardia is where the vagal response is too much due to scoping or insufflation, and desaturation in cardiac patients, especially in cath labs. So in summary, NORA requires the same standard of care as the OR. Vigilance is paramount due to remote location and ergonomic challenges. Understanding the specific pathophysiology, especially in cath lab and physics and MRI, is essential for safety. And this last line in the last slide is the most important, that there are no minor anesthetics. Procedure may be minor or major. Anesthesia is always major for any child. Thank you.
Long time करेगा.
Thank you, Dr. Harick. So this concludes our masterclass on pediatric anesthesia from historical roots to modern mastery. We are ready to take any questions. If anyone having any questions.
Questions to me, I check in.
So thank you everyone for the patient listening, and hope we have emphasized the importance of pediatric anesthesia care, and that's all. Thank you. Have a good evening.